Today's video will go over chest and pleural trauma, which includes pneumothorax and flail chest. Flail chest. Flail chest wall motion is the result of double fractures of at least 3 or more adjacent ribs, which causes the thoracic cage to become unstable, or to flail, which is defined as to wave, swing, or have abnormal movement. The affected ribs paradoxally cave in or flail during inspiration as a result of the generated subatmospheric interpleural pressure. This compresses and restricts the underlying lung, and sharp rib fragments may also damage the underlying tissue and large blood vessels, in some cases creating a pneumothorax, which we'll talk about next. This can cause a restrictive lung disorder. There may also be pulmonary contusions present, or alveolar hemorrhage or lung damage to the lung tissue under the fractured ribs. Sharp rib fragments can puncture the diaphragm, spleen, liver, and large blood vessels. Hallmarks of a flail chest include double fracture of numerous adjacent ribs next to each other, rib instability, lung restriction, atelectasis, lung collapse or pneumothorax, lung contusion, and secondary pneumonia. The image shows a flail chest with double fractures of 3 or more adjacent ribs, the hallmark of a flail chest. This produces instability of the chest wall and paradoxical motion of the thorax. Inset to the side is atelectasis of the alveoli, which is a common secondary anatomic alteration of the lungs. So why does this happen? This happens secondary to motor vehicle accidents, such as an unrestrained passenger that takes a steering wheel to the chest, slips and falls, blast injuries, often seen in construction, direct compression by a heavy object. I've actually seen this happen at work from a fall with a horse, and the horse fell on the person, or in industrial accidents such as mining, things like that. What will you see on chest x-ray? Increased opacities, rib fractures, increased density on the affected. This is a chest x-ray of a 20-year-old female with severe right-sided flail chest, pictured in the first chest x-ray. In the second, you can see a close-up of the same x-ray film demonstrating the rib fractures. So how do we treat flail chest? Well, in mild cases, we give pain medication and use routine airway clearance techniques, and that's all that's really needed. However, in more severe cases, we may have to use a ventilator. The patient may need to be sedated and ventilated, and they may need to be on the ventilator with sedation for 5 to 10 days, giving the time for sufficient bone healing. Oxygen therapy is used to treat hypoxia and decrease the work of breathing and decrease the work of the heart. It should be noted that hypoxemia that develops in flail chest is most commonly caused by Elvis and capillary shunting associated with the disorder. Hypoxemia caused by capillary shunting is often refractory to oxygen therapy. Lung expansion therapy. Lung expansion techniques are commonly used to offset and prevent alveolar consolidation and atelectasis associated with flail chest. Mild pain relief may be helpful if the pulmonary expansion technique used causes excessive pain. Please make sure the nurse gives pain medication prior to having a patient do their IS, and make sure they use a pillow to help splint. These will all help with pain control. Because acute ventilatory failure is associated with flail chest, mechanical ventilation protocols may be used. It's often used with PEEP so that adequate ventilatory status can be maintained. Ventilator initiation and management protocols and weaning protocols are necessary. Now let's talk about pneumothorax. A pneumothorax exists when gas, sometimes called thoracic free air, accumulates in the pleural space. This enhances the natural tendency of the lung to recoil or collapse and the natural tendency of the chest wall to move outward or expand. As the lung collapses, the alveoli are compressed and atelectasis happens. In severe cases, the great veins may be compressed and cause venous return to the heart to diminish. A pneumothorax produces a restrictive lung disorder. The major pathologic or structural changes associated with a pneumothorax are lung collapse, atelectasis, chest wall expansion in tension pneumothorax, and compression of the great veins and decreased cardiac venous return. This shows a right-sided pneumothorax seen in GA, gas accumulation, a depressed diaphragm, DD, and a collapsed lung. The inset shows atelectasis, which is a common anatomic alteration of the lung. Gas can gain entrance to the pleural space in 3 ways. 1. From the lungs through a perforation in the visceral pleura. 2. From the surrounding atmosphere through a perforation of the chest wall and parietal pleura, or rarely through an esophageal fistula or perforated abdominal viscus. And from gas-forming microorganisms in an empyema in the pleural space, though this is rare. Let's talk about classifications or the general terms. There are closed pneumothoraxes, open pneumothoraxes, and tension pneumothoraxes. In a closed pneumothorax, gas in the pleural space is not in direct contact with the atmosphere. An open pneumothorax, however, is a condition in which the pleural space is in direct contact with the atmosphere, such that gas can move freely in and out. A pneumothorax intrapleural pressure exceeds the intra-alveolar or atmospheric pressure is known as a tension pneumothorax. Some forms of pneumothorax are identified also on the basis of origins, and we'll look at those shortly. This is a sucking chest wound with accompanied pendulum in an open pneumothorax. The large arrow illustrates the chest wall injury. Next is a closed tension pneumothorax produced by a chest wound. The large arrow illustrates the chest wall injury. and this is a right pneumothorax produced by a rupture in the visceral pleura that functions as a check valve. The progressive enlargement of the pneumothorax occurs, producing atelectasis on the affected side. Pneumothorax based on origin. These include traumatic pneumothorax, spontaneous pneumothorax, and iatrogenic pneumothorax. Let's talk about traumatic pneumothorax first. Penetrating wounds to the chest wall from a knife, bullet, or impaling object in an automobile or industrial accident are common causes of traumatic pneumothorax. When this type of trauma occurs, the pleural space is in direct contact with the atmosphere and gas can move in and out of the pleural cavity. This condition is known as a sucking chest wound. It is also classified as an open pneumothorax. A piercing chest wound may also result in a closed or valvular or tension pneumothorax through a one-way or check valve of a ruptured parietal pleura. In this form of pneumothorax, gas enters the pleural space during inspiration but cannot leave during expiration because of the parietal pleura, or infrequently because of the chest wall itself acts as a check valve. The condition may cause the intrapleural pressure to exceed the atmospheric pressure in the affected area. Technically, this form of pneumothorax is classified as a tension pneumothorax. This form of pneumothorax is more serious because gas continues to accumulate in the intrapleural space and progressively increases the compressing pressures on the lungs and mediastinum. When a crushing chest injury occurs, the pleural space may not be in direct contact with the atmosphere, but the sharp end of a fractured rib may pierce or tear the visceral pleura. This may permit gas to leak into the pleural space from the lungs. Technically, this form of pneumothorax is classified as a closed pneumothorax. Spontaneous pneumothorax. When a pneumothorax occurs suddenly and without any obvious underlying cause, it is referred to as a spontaneous pneumothorax. Spontaneous pneumothorax is secondary to certain underlying pathologic processes such as pneumonia, tuberculosis, COPD, and can happen almost instantly for a number of reasons. It may be the rupture of a small bleb or bulla on the surface of the lung. This type of pneumothorax often occurs in tall, thin people aged 15 to 30 and may result from high negative intrathoracic pressure and mechanical stress in the upper zone of an upright lung. A spontaneous pneumothorax may also behave as a tension pneumothorax. Air from the lung parenchyma may enter the pleural space via a tear in the visceral pleura during inspiration but is unable to leave during expiration because the visceral tear functions as a check valve. This form of pneumothorax is classified as both a closed and a tension pneumothorax. This is a picture of a 19-year-old male patient that's 6 feet 5 inches tall who experienced a sudden spontaneous left-sided pneumothorax while playing a round of golf. A spontaneous pneumothorax is not uncommon in people who are tall and thin. In B shows a chest x-ray of the same patient's 45 minutes later in the ER. Note the shift of the heart and mediastinum to the right toward the affected side, away from the tension pneumothorax and the depressed diaphragm on the patient's left side. Let's talk about iatrogenic pneumothoraxes. An iatrogenic sometimes occurs during a specific diagnostic or therapeutic procedure in a hospital. That means something that we did as healthcare providers caused the pneumothorax. For example, a pleural or liver biopsy, thoracentesis, intercostal nerve block, cannulation of a subclavian vein, or a tracheostomy. An iatrogenic pneumothorax is always a hazard during positive pressure mechanism. Clinical manifestations that are associated with pneumothorax. Atelectasis. What will you see at the patient's bedside? Vital signs. Increased respiratory rate, or tachypnea. Several pathophysiologic mechanisms operating simultaneously may lead to an increased ventilatory rate. Stimulation of the peripheral chemoreceptors, or hypoxemia. Pendeluff, and decreased lung. As gas moves into the pleural space, the visceral and parietal pleura separate, and the lung on the affected side begins to collapse. As the lung collapses, atelectasis develops and alveolar ventilation diminishes. If the patient has a pneumothorax as a result of a sucking chest wound, additional mechanism may also promote hypoventilation. When a patient has this type of pneumothorax and inhales, the intrapleural pressure on the unaffected side diminishes. As a result, the mediastinum often moves to the unaffected side, where the pressure is lower, and compresses the normal lung. The intrapleural pressure on the affected side may also decrease, and some air may enter through the chest wound and further shift the mediastinum toward the normal lung. During expiration, the intrapleural pressure on the affected side rises above atmospheric, and gas escapes from the pleural space through the chest wound. As gas leaves the pleural space, the mediastinum moves back toward the affected side. Because of this back and forth motion of the mediastinum, some gas from the normal lung may enter the collapsed lung during expiration and cause it to expand slightly. During inspiration, however, some of this rebreathed dead space gas may move back into the normal lung. This paradoxical movement of gas within the lungs is known as pendeluff. As a result of the pendeluff, the patient hypoventilates. Therefore, when a patient has a pneumothorax, alveolar ventilation is reduced because of lung collapse and atelectasis. Vital signs continued. There is decreased lung compliance and increased ventilatory rate relationship. Activation of the deflation receptors, activation of the irritant receptors, and stimulation of the J receptors, as well as pain and anxiety. Increased heart rate, increased blood pressure, and cyanosis. There may be a hyperresonant percussion note over the pneumothorax and diminished breath sounds over the pneumothorax. Tracheal shift away from the affected side in a tension pneumothorax, displaced heart sounds, and increased thoracic volume on the affected side, particularly in a tension pneumothorax. As gas accumulates in the pleural space, the ratio of air to solid tissue increases. Percussion notes resonate more freely throughout the gas in the pleural space and in the air spaces within the lung. Because of the ratio of extrapulmonary gas to solid tissue increasing in a pneumothorax, hyperresident percussion notes are produced over the affected area. This shows the sound transmission with the gas accumulation when you tap on the chest wall. Breath sounds may be diminished as gas accumulated in the intrapleural space. This shows how the gas accumulation may muffle the diminished breath sounds, and why. As gas accumulates in the intrapleural space, the chest diameter increases on the affected side in a tension pneumothorax. Lung volumes and capacities have a restrictive pattern. In a small pneumothorax, blood gases may show acute respiratory alkalosis secondary to an increased respiratory rate with hypoxemia. This shows disease onset and at the point at which the PaO2 declines enough to stimulate peripheral oxygen receptors. Acute ventilatory failure with hypoxemia is seen when there's a large pneumothorax. This shows acute respiratory acidosis with hypoxemia. These are the oxygen indices and hemodynamic indices. On chest X-ray, there is increased translucency on the side of the pneumothorax. It's dark, it's full of air. The mediastinal shift to the unaffected side in the thorax should be able to be seen, and there's a depressed diaphragm as well as atelectasis. Let's take a look at this. Shows development in A of a small tension pneumothorax in the lower right lung where there's an arrow. The same pneumothorax 30 minutes later is shown in B. Note the shift of the heart and mediastinum to the left away from the tension pneumothorax. Also note the depression of the right hemidiaphragm, again where there's an arrow. So what do you do for pneumothorax? Management of the pneumothorax depends on how much of the lung has collapsed. When the pneumothorax is relatively small, only 15 to 20% of the lung, the patient may need only bed rest and limited physical activity. In such cases, reabsorption of intrapleural gas usually happens within 30 days. However, when the pneumothorax is larger than 20% of the lung, it should be evacuated. A chest tube should be placed and suction is used. The negative pressure should not exceed -12 centimeters of water pressure. -5 centimeters of water pressure is usually all that's needed. After the lung has re-expanded and bubbling from the chest tube has stopped, the chest tube is left in place without suction to water seal for another 24 to 48 hours before it's taken out. When a patient has spontaneous pneumothoraxes over and over again, pleurodesis may be used. A chemical or medication can be injected into the pleural cavity to help sclerose the pleura together. Sometimes talc, tetracycline, or bleuromycin sulfate are used. This is a very painful procedure. It produces an inflammatory reaction between the lungs and the inner chest cavity and causes the lung to stick to the chest cavity. It doesn't work all the time, and again, it's extremely painful. It should be done in a hospital by trained physicians. What will you do as a respiratory therapist? Oxygen therapy is used to treat hypoxemia and decrease the work of breathing and decrease the heart's work. It should be noted, however, that hypoxemia that develops in a pneumothorax is most commonly caused by atelectasis and capillary shunting associated with this disorder and may be refractory to oxygen therapy. You will also use lung expansion techniques. However, you must use caution when doing this, especially prior to chest tube placement. Mechanical ventilation may be required if there's acute ventilatory failure. Continuous monitoring and PEEP may be required to maintain adequate ventilatory status. And a chest tube is required in times of tension pneumothorax immediately. Thank you for your time and attention today. This concludes our talk about pneumothorax and flail chest.